Our next presenter is Dr. Catherine Dillon. She is a board-certified anesthesiologist originally from Yardley, Pennsylvania. She completed her residency at Thomas Jefferson University, where she developed a strong interest in neuroanesthesia and obstetric anesthesia. She will be speaking on new techniques for epidurals. Please join me in welcoming Dr. Dillon.
I'm Katie Dillon, as DP nicely introduced me. I'm going to talk about new techniques for labor epidurals, specifically focusing on the lumbar spine, obviously. We can open up a can of worms with going into the thoracic spine, but we'll just stick to OB. Throughout this talk, I'm mainly going to focus on ultrasound for a large portion of this talk. As the Huffnagels just kind of explained, epidurals are a technique that we do and have been doing very similarly for a long time. So these new techniques and new equipment and different infusion strategies that I'll talk about in the upcoming talk will really just be adjuncts to something that we successfully do every day. And a lot of people have a lot of strong preferences on what they use. I'm personally a plastic syringe with air, but these are all just things that you can use very easily in your daily practice or change that could help you a lot with successfully achieving epidurals. So like I said, first I'm going to talk about ultrasound and its use and how to help place an epidural, just some new equipment that is around and is starting to become more widely available. And then briefly touch upon different infusion strategies and drug choices and adjuncts that you can use. So first, like I said, we'll start with ultrasound-guided epidural placement. So you're able to see more accurate anatomy with an ultrasound. A lot of the time that we're placing epidurals, we're using anatomical landmarks where we believe will be something that we can find or feel, but a lot of the time that's not usually accurate. We can use what we think is L4 is actually higher or tends to be lower, especially with different body habitus and the growing population of parturients that are larger in size or have different edema, just in general different body habituses. Anatomic landmarks are often unreliable in these patients, and using ultrasound will be able to give a real-time use to identify different things like ligament and flavum depth, which I'll go over, how to calculate or look at for a good guess, interspinous space, and mainly using midline trajectory and just getting a sense of where you are, and just more actual information rather than guess and feel, which is often what we use in this blind procedure. So overall benefits, like I said, are just adjuncts to helping place a successful epidural. It improves the success rate, especially in difficult anatomy and larger patients mainly. Reduces needle redirections and traumatic insertions, minimizes dural puncture, and again, just overall having a more successful epidural placement. All right, so first things first, you're looking for midline. So overall, we're going to discuss just a general scan of the back and what you should see, so that when you know what you're looking for, midline, and then if you've gone too far, kind of what would be past that, so that you know when to scan back and forth. So when the probe is over midline in a sagittal orientation, which is what you see here, you don't really see much at all because we're over the spinous processes and the supraspinous ligament, and there's a barrier to sound penetration. So you'll see these dark areas. Let me slide back there. You'll see those dark areas in the center, which are lightly highlighted by kind of like a faded line over there. You're not really seeing much. This isn't really helpful. So that would be what directly is midline. This is obviously a dynamic process with ultrasound, so that's what would be true midline, and then sliding off, which I'll show in continuous slides on how to place the best landmark for yourself. So this is totally midline in the sagittal view. Then as you move laterally onto the laminae, you'll see a row of triangular structures, which again are highlighted in kind of the faded white there, that look like an alligator tail. From there, we'll come back to this view. This is kind of the ideal view. You'll tilt slightly medially where you're able to have a better view of the intralaminar space. And like I said, we'll return to this view as our major landmark on where we're X out in the back, which I'll go through at the end. And then, just like I said, for completeness sake, this is moving just continually more laterally. You're going to be over the articular processes here. You'll see something that more looks like rounded speed bumps there as you go along, rather than the alligator tail with the points. So this means you've kind of gone a little bit too far and you're to slide more towards midline for marking out your space. And then going over to the last bit, this is, again, still in sagittal view where you're over the transverse processes. So again, as you kind of move more to the side, there's more spaced out bumps that delineate the transverse processes, as you see there. So the goal of the ultrasound is, like I said, to create an anatomical roadmap for yourself. So the next, you switch from the sagittal view over to the transverse view, which is just turning your probe. And again, I didn't mention this before, but as seen kind of in these images, you're using the curvilinear probe for most of these. Especially, again, if you're using this for somebody who's of larger habitus, you want to be able to have that penetration. So here's a view at the level of the interspinous space, which is our goal of what we want to see. We see a faint shadow over the spinous processes, which again is highlighted there. We also can see the laminae, which are the white lines kind of off to the sides, and then the articular processes, which are kind of like the top edge of the points at the top of that image there. And depending on your view, you can see transverse processes on the lateral portions, which are those white sides kind of on the other side of the darker images. This pointer is not, oh, there we go, perfect. This is laminae, articular processes in the top, and then transverse processes. Also of note, keep in mind this is kind of like the perfect image. A lot of the time we are looking at these patients with less than perfect anatomy, difficult to visualize, and very deep. This is, like I said, likely on a skinnier patient or somebody that doesn't have a lot of subacute tissue that we're going through, or edema or something that would obscure these images. Often you will not see the transverse process. Often you'll not see this perfect of anatomy. So something to definitely keep in mind. So then below this, so this space here, right above the spinal canal is the posterior complex, which is highlighted in yellow, which is a light band comprised of the durum and the ligamentum flavum. Deep to that's the anterior complex, which is the dura and the vertebral body, and then the green center is the thecal sac, obviously. This view is characteristic of a bat or bat shape, kind of like the little bat signal there. That's something that you're looking for in this portion. So the goal is to be just below the spinous process and see this view in the transverse view. And if you're over the spinous process, you obviously won't see this and it will be completely obscured. So now that we know the anatomy and what you're kind of looking for in the scans, how do you do it? How do you use this to help you place the epidural? So again, creating a roadmap for yourself. You're going to place different lines. Like I said, with the view initially, with the sagittal view, you're going to go for midline, scan slightly laterally, angle medially, and place a line at each view. So starting the procedure, you can start at the sacrum or something where you have kind of more definitive anatomy in the sagittal view, slightly off midline, tilt your probe, and you're able to count up to whatever desired interspace, again, knowing kind of complete anatomy and absolute rather than just using arbitrary landmarks that we typically use when placing it. And you're able to mark out not only one space, but kind of higher up if you were to have an unsuccessful attempt or you were struggling to place it at that, it gives you more spaces to find it. So you would mark out each one of those. Then you would turn your probe to the transverse view, search for that bat sign, and mark that as well. And you would create sort of a landmark, like you see there, placing the horizontal lines at those places so that you kind of have an X marks the spot as you go up the spine and have possible attempts. You're trying to stay as close to the horizontal lines that you possibly can. So in theory, once that view is in place, you can use electronic calipers, like I said, to measure the distance from the posterior complex to the surface, which could give you an approximation to the epidural space so you know how to go or how far to go. But remember, again, this is not perfect anatomy, or here is perfect anatomy and not something you're using in practice. And you're typically compressing the subcu and the skin when you're ultrasounding in general. So this is just kind of a guide. So you would measure from here up and use the electronic calipers and a frozen image that you could have a guesstimate of how far you would go. But again, it's without its limitation. So something to keep in mind. You don't want to use this as an absolute distance. It's still based on feel, and this is an adjunct to your normal practice. So that's kind of how we would start, and you would map it out and use your normal technique in a difficult anatomy patient. Moving on to some new equipment. I think a lot of us are very hesitant to use different plungers or kind of the new technology that it's seen, such as there's a couple different companies that use similar technology, produce similar syringes. Some are Epicure, Autodetect, Epifaith, Parafix. All of them use their own indicators for how they alert you that you've reached a pressure change. One of the ones that I found to be maybe like the most useful is one that you do your normal technique. It just has an extra kind of indicator for you that there's a pressure change. It doesn't, significantly change your practice, which is the one over to the right there. It's a plastic syringe that essentially has a smart signal. It will flag when there's a pressure change, but in the event of a false loss, or if the person administering the epidural is unsure if that's actually where the space is, you can push the plunger, and if a true space was achieved, the plunger should empty as if you're doing your normal technique, normal loss. But if a false loss is confirmed, the syringe will actually repressurize and reactivate that signal, and you can continue to advance as, again, you would as kind of typical. You're able to normally just produce your normal technique, but these are just kind of adjuncts. But this is really the only one that I saw that again is you're able to add to your practice rather than completely change. I know I myself would be kind of apprehensive to completely trust new technology rather than myself or someone that's doing it often. Another kind of changes, which we'll hear in the next hour from both Drs. Huffnagels, will be infusion strategy. So I'll briefly just touch upon it. One is programmed intermittent epidural bolus, kind of a change from the continuous one, which I'll go over kind of the difference between the two very briefly. This is, you're able to, instead of a continuous fusion, give different boluses that continue throughout the laboring process at different intervals, which I'll go over. It can be combined with patient-controlled epidural anesthesia, or PCEA, and it will deliver scheduled larger boluses rather than that continuous flow we're used to. It's been shown to have better spread of local anesthetics, less of a motor balk, reduced need for clinician-administered top-offs, decreased total local anesthetic consumption. And this is just a proposed dosing. It's not on there. I must have left it off there, but it's for bupivacaine, usually at a concentration between 0.0625 and 0.1%. So that's kind of a proposed way to program the pump. One thing to note with these is PIEVs do need a good working level before the pump is really allowed to take over because of built-in timing delays. And it's important to notice when you're starting the epidural, you have to give adequate bolus so that you have an adequate pain control level. And then just going over quickly, continuous epidural infusions. These also can be combined with PCEA. It's a steady state infusion that we're used to, more predictable, but less of a dynamic spread. and higher risk of unilateral block, dense motor block. And again, this is just kind of a proposed dosing that could be, again, combined with PCEA. This is just a more concise version comparing the two, the PIEV on the left and then the continuous infusions on the right. Like I said, just going over more what I have already kind of delineated. Main thing too, looking over onto the right graph is less top-offs are needed by physicians. So in a busy OB floor, it's advantageous for us to not have to continually give top-offs throughout the laboring experience for moms, which is overall better patient satisfaction for them as well. And just to finish off, two more adjuncts that you can add to those different infusion strategies that I delineated are different drug choices. Kind of giving favor is switching from bupivacaine, which a lot of us use, is switching to ropivacaine, which I know I kind of at the tail end of my residency had switched over to. Ropivacaine is giving favor because of the lower cardiotoxicity and motor block potential. And then just below are different additives that you can add. Again, we're commonly used to having fentanyl in epidurals, but you can also, there's been new studies in adding clonidine or Precedex as an adjunct and as part of the infusion strategy rather than giving boluses as determined by the clinician during the laboring process. And just further going over how dexmedetomidine can be used as an adjunct. They're under study for using them as in synergy to what we always use, and it could enhance analgesia, reduce physician boluses, minimize motor block, and then there are some proposed studies that it can have vasoconstrictive properties that may delay systemic absorption for local anesthetics. And then again, that's just kind of a dosing possible concentration that could be added. Thanks so much.
Thank you so much, Dr. Dillon. We'll now begin the Q&A portion of the lecture. If you have a question for either Drs. Huffnagel or Dr. Dillon, please come up to the microphone on the floor. Okay, I'll start. Dr. Suzanne Huffnagel, I know you're a fan of the bromage technique. How does saline influence this choice?
Is this on? Can you guys hear me? Sounds on. Okay. I don't know that it really influences whether you use air or saline. My sister made the argument that you can lose a lot of saline when you're trying techniques. So it's not on. Hello? Okay. That one isn't either. When the continuous what she's talking about is I put my hand on the end of the plunger and I advance together rather than intermittent going back and forth. I mean, I personally think when you're using saline, if you're not constantly moving, and you're keeping everything together like this, the syringe stays on the end of the epidural needle better, and so you're going to lose less saline. So I think that just a smoother transition. All the other arguments I made that she tried to say, oh, stuff comes back, I mentioned how you can figure that out. So I think that a continuous technique with saline is probably the smoothest, fastest thing.
For Dr. Dillon, now you were showing, the ultrasound machine. Have you ever used the one that's specifically made for epidural? And the Accuro device, I've had one for many, many years, and I find it very helpful for people that aren't skilled sonographers because it has the AI guidance and gives you the overlay of the interspace. All that you showed with all the views and everything would probably take me 15 minutes to be comfortable finding the epidural space, whereas with the Accuro, I use it in almost all of my 50 BMI patients where I can't really feel landmarks, and I'm usually able to find the interspace with the depth of the epidural space in under a minute. And I also use it for my difficult spinals, for orthopedic cases and people with scoliosis or severely arthritic spines, and I'm also highly successful using that device. I had one for many years, and then it finally died, and my health system would not approve it because they said they had, other handheld ultrasound devices like the Butterfly, but you run into the same problem. It doesn't have the specific AI guidance that the Acuro device has. So I bought one myself at the ASA because I believe in this device so much. And I'm just wondering why people don't talk about it or use it or think about it. Do they consider it cheating? I mean, I know when ultrasound started coming out for regional anesthesia or A lines or central lines, all the old docs were like, well, I've been doing it with nerve stimulator. I've been doing it with landmarks. I mean, this device just seems groundbreaking, and I'm just surprised more people aren't using it. I've had first needle success pass in 90-something% of those difficult patients.
Yeah. This is working. I really just addressed epidural or placing it with ultrasounds that a lot of people have. Not using that specific device because, as you kind of said, it's not widely available. Seemingly, your hospital or institution isn't even supporting you in getting you one. But not to say that that's not something that's useful and helpful. And I absolutely understand that it's difficult for you to place and using with the traditional ultrasound and technique, but that's kind of the goal, right? You want to use a tool that you have accessible to you all the time and get faster and better at using it to just help you place an epidural quickly for these patients. But that's, like I said, not to say that that device is not extremely helpful.
Why do you think the trend has shifted towards teaching with saline versus air?
That's an interesting question. I can only speculate that people are looking towards what other places are doing, UK and Canada, and seeing that they're using saline and that they're going along with me and seeing all these complications with air. And also people doing more pediatrics are preferring saline. So they're smart people. They're going along with me.
No, it's called brainwashing. That's what it is.
A glass syringe that's fully coated, and then primarily 3 to 4 cc's of saline with a small bubble of air as I'm advancing the epidural needle. And in my mind, that replaces that smart indicator on the epiphyse, that senses a change in pressure. As fluid is not compressible, air is. When you are advancing toward the epidural space, you'll see the compression on that bubble, and then as the needle goes through the space, that compression is released, and that bubbles becomes spherical again inside the syringe.
Well, that is interesting, and I have not used it. I've seen people use it, so I can't say I have experience with it. But I can tell you, I know air is compressible, but I know the feel, and I know the feel when I'm going to lose it. But that's because I've been doing this for 37 years. So I don't doubt that that is a good technique. I didn't see a lot of literature on it, though, so maybe it's not as common. But
No, it's not as common. The literature I have shows that many fewer people are using it. Maybe it's just because you have to do two things rather than just drop saline or just use air. I don't know, but it definitely is by far and away less common.
And I looked at the epiphyse. We haven't tried it yet. It looks fabulous, but we haven't used it. But Dr. Who at SOAP does it? Michaela Farber had a presentation on it. It looked fabulous, and on the models it was great. But again, have to try it. And it's a plastic loss of resistance syringe with air.
Okay, I guess I'm next then. We were having a discussion of the same thing, and at our table, we used the saline with an air bubble to give that pop that you get when you get into the epidural space. The question that I actually have, though, is When you guys were flipping coins, who got which side? I'm assuming that Suzanne won.
No. Absolutely not. She was director of OB anesthesia at the time, and she said, "This is what I'm talking on," and then I got what was left. We don't routinely use saline. Again, we teach so many residents. To me, it's just more difficult teaching residents with saline. I personally have used saline. It's a better loss. It's an all or nothing loss, but it just confuses the issue when I'm teaching. And I'm, like I said, the preference, I was taught with air. I like air. I use air. I'm very comfortable with air.
Add the air to your saline syringe and you'll find you've got the best of both worlds.
I'm sorry.
Add air to your saline syringe and you have the best of both
I'd like
worlds.
to try that.
I mean, that's interesting, that they, again, I haven't seen any studies, of that since like 2010, when Adzamelli looked at that. So it may be something, another study that could be done, because I don't think there's anything in the literature with it recently at all.
Thank you. This has been a really great session. My question is actually for Dr. Dillon. I'm going to switch gears from the air saline discussion, although I'm with some of my other colleagues over here. I like saline with a little bit of air. For Dr. Dillon, you mentioned at the end of your presentation about the addition of Precedex. Have you seen that used more regularly as like part of the mixture? We've started using it a little bit more as like a bolus, more for like transitioning an epidural to like a surgical block. But I thought it was very interesting that you mentioned adding it to the mixture. What patient group would you select that for? Is this something that's like routinely done? Are there any issues with that? Have you heard of any hypotension, bradycardia issues?
Yeah, so I really just saw it in literature. I also am more familiar with using Precedex in a bolus fashion, or again, transitioning into a surgical block, or during a C-section that moms are acutely uncomfortable, kind of more in that aspect. I think there's a lot of limitations on the pharmacy doing it, and like having the cartridge, having the infusion pumps, like having the infrastructure to place them. So I really only just read about it, which I thought it was interesting to add. And I think, again, you would use them in the same kind of patient population, someone that you'd be concerned about controlling their pain during labor, or if you're struggling, you could in theory switch it to that. But again, it wasn't really, I'm more familiar with bolus as well, rather than just the patients that used it on.
I can give a little experience too, not that I've used it a lot because I haven't, but there are two studies from last year, I think, out of China. One was maybe 2020, the other one was 2024, I think, with it for C-sections. I don't have any experience with it in labor, but in C-sections, the intrathecal dose they recommended was 5 micrograms. The epidural dose, they looked at 0.5, 0.75, and 1 mic per kilo, and they came up with 0.5 mics per kilo as the optimal dose. And what they found was it decreased that visceral traction reflex when they exteriorize the uterus, which all of our OBs do, which is the bane of all of our existence with epidural C-sections. And that's when a lot of our epidurals fail, because the patients just can't tolerate that. And we have not been able to change the mentality of our OBs yet. It is not FDA approved neuraxially. So that's an issue. And in Philadelphia, where we have so many lawyers per square inch, we have to be really cognizant of that. It doesn't mean you can't try it. And a few of us, I think Dr. Wenzel has tried it. But it can, in those doses, increase the motor block. So you can have patients being in your PACU for extended periods of time, because it does make the motor block when you're using those doses more. Now, I haven't used it in labor. I don't have any experience with it in labor. In those Chinese studies, the higher the dose after the 0.5, you had more thirst and you had a little more sedation, which they didn't think was a bad thing, because people were nervous coming to have their C-sections as well. So with that dose, I don't see any downside, except that the nurses are going to be on our cases for people being in PACU a lot longer. But if the OBs are not going to stop exteriorizing the uterus, we are really kind of in a crisis situation, and we have to do something because we are just not able to deal with it very well. So I think that's going to be an answer, but we got to deal with the consequences of that too.
That spring-loaded epidural, when I saw the advertisement, I thought it was kind of cool. Have you ever used that before? Or?
No, I haven't. I really have just used the Epifaith at ASA, yeah. And,
Is that the EpiZap? Yeah, I think we've looked at it at
It'll
conferences. It's kind of bulky.
It is.
It's kind of scary. So we didn't
We haven't
pursue it
used
because
it
I
yet.
love the EpiFaith looked great.
And like I said, I looked at a couple different things, more online and in videos on their websites. The Epifaith, it allows you to kind of do your normal thing versus something that's like automatic. I struggle a lot with new technology that would like override me, rather than something that I'm like, oh, this is a change, something that's helping me.
Can you use saline in the EpiFaith?
I don't know that actually.
I mean, I want to say you can because there are a lot of saline users out there. We know that from my talk. But I'd have to contact the company about that too. But we liked it too. We haven't really tried it on patients. They were talking about doing some kind of a study with us, but they haven't contacted us yet about it. But, you know, like her, I don't want to lose my sensitivity in my hands. I'm an old dog. And this is old dog, my new tricks. They're new tricks, but I'm an old dog. I admit it.
I guess this is more of a couple comments, some of the other questions and comments I've heard. As far as the AI ultrasound, we have one of those that we use in labor and delivery as well. We use it, I find it useful for teaching students, but myself, I always use the classic ultrasound more because I don't like the computer telling me what I'm doing, and I'm pretty confident with ultrasound. So I do find it very helpful for teaching students, residents, of what proper anatomy is and where you should go. But for larger patients or for myself, I choose normal ultrasound. I found that equally useful. As far as the saline versus air, I think no one's going to change their practice. We all are pretty confident what we do. I've tried all of them. I'm an air purist myself, but when I've mixed the saline and the air, rather than being best of both worlds, I see almost the worst of both worlds. Because the great thing about a saline epidural is you have that hydrostatic column and you have a no, 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 yes answer. With air, if you mix it, you lose that. And if you just air, then you avoid all of the complications like, is this CSF, is it not CSF? Am I creating a false pocket, those kind of things. So having just air, you avoid all those saline complications. Whereas you mix, you kind of have both the problems of both.
That's why I think it's a great debate, because there are staunch supporters on either side, and there are issues on both sides, and I don't know that we can get them all away when we use a combination of one or the other. So, great debate.
Also, for the record, both of them taught me how to do epidurals. I think Jane was my first one ever, so I might be biased. Might be.
Any other questions? Okay, well then please join me in thanking Drs. Jane and Suzanne Huffnagel and Dr. Dillon for this great talk.